Hi, welcome back to my channel. In this video, I will be talking about twin block. So, first of all, you should know that it is a myofunctional appliance and it was given by William J. Clark. Alright, so you should know the name of the person who gave the appliance. So, now twin block, it was a natural progression in functional therapy. Now, what do you mean by this? Is that there was a transition from one piece appliances to twin appliances. Now, let's just know what is twin block exactly doing. So, first we'll talk about the mode of action. So, if I have to talk about the mode of action, so in this mode of action, what you want to know, see, first of all, what happens is we have some favorable cuspal contacts in distal occlusion. Now what we basically do is we replaced by some favorable proprioceptive contacts on inclined plane to correct malocclusion and free the mandible from its locked position. Now this leads to the masticatory forces are transmitted via the appliance to dentition, right? So these lead to the change. Basically, they change the rate of growth and the trabecular structure of bone. Okay, now let's talk about the components. So we've talked about the mode of action. Now we'll talk about the components. All right, so just give me a second. So now let's talk about the components. All right, so components. Now in components, you can have a midline screw in expansion cases. Then you have delta clasps and ball end clasps. Now ball end clasps are in anterior and delta are in posterior, and these clasps will be given in the in mandible. They'll be given in the premolar and molar region, and in maxilla they'll be given in premolar and incisor region. All right, and then you will have the opposite bite blocks, the hero opposite bite blocks. And now here you should know the evolution. See, first we said that it is 90, then we said that they are inclined at 45 degree, and now we say that they are inclined at 70 degree. Now what's the difference between all of them? When it was inclined as 90 degree, what happened was we came to know that the this led to the occlusion. This led to the occlusion in old distal occlusal position. Then we switched on to the 45 degree. Now what happened was it generated equal and horizontal forces, but it was leading to undesirable vertical forces which affected the treatment course. Okay, now let's talk about the 70 degree. Why we switched to 70 degree? Now 70 degree gives us a better horizontal force. Okay, and it decreases the vertical force. So it ensures proper mandibular advancement. So now you have to know that the angle that we use is 70 degree and not 45 degree. Alright, now let's talk about the indications. So indications. So it is indicated in the class 2 div 1 with overjet plus deep bite cases. It is only used in well aligned arches, growing stage, and it should give a positive VTO. What is VTO? Is visual treatment objective. What happens is you will ask the patient ki before doing the treatment only ki bring your mandible in front, like bring the mandibular teeth to occlude in front. Then what you will see is that the person ka class 3 will shift into something better. Either it will be class 1, maximum is class 1, near class 1 basically. Alright, so you will see a change in the profile of the patient. Like you will see a betterment in the profile and all the facial soft tissue part also. So like obviously if this person is, suppose someone is like this and they have like this, suppose this is class 3 and this is class 2, like piche ko. So wait, I'll explain better. See, suppose you have a person, so this is the nose and these are the lips, and this person is like this. So and then one more person and he's like this, and then one person is like this. So this is 3, this is 1, this is 2, and this is 1. So if you ask this patient ki bring this forward, bring your mandible forward, then he will obviously look like this, right? And this is what we want to achieve. So it is giving us a positive visual treatment objective. This is what is called as positive VTO, visual treatment objective. Then let's talk about the contraindications, like where you cannot give. So contraindication. So obviously you will not give in a class 2 case, which is because of the skeletal maxillary prognathism. See, it acts only on the muscles and it basically acts on the functional activity, right? Then you can't use it in a vertically directed grower. Then labial tipping of mandibular incisors anteriors. Then crowding. Okay, now there are certain stages in the treatment. First let's just see the photograph of a twin block. So we'll just use a few photographs so that we have a visual memory. Alright, then yep. So see, I'll add it here. Okay, and this is somewhat here. So let's talk about the components. So I told you that we have an inclined plane directed at the angle of 70 degree. So this extends from the posterior to the mesial ridge of second premolar, and here it extends to the distal marginal ridge of second premolar पर mandible में, और इधर is maxilla, right? Then see this is our ball end clasp. Okay, then you can see the acrylic also, right? Adams. So delta clasp. So now let's talk about the stages are left. So let's just go through them swiftly. Stages. So there are only 3 stages. 1, 2, 3. Active, support, retention. Active is 7 to 9 months, support is 3 to 6 weeks, retention is 9 months. In this overbite correction, then in support, use of inclined planes, then in ninth, retention of the corrected, and appliance is shifted to night time, where only when occlusion is fully established. So this completes our thing about twin blocks. So I've covered most of it, like I've covered all of it mostly. So you can also use it for orthopedic traction also. Okay, then yes, I've covered it all. So yeah, if you like the video, do subscribe to my channel. So if you found this video helpful, do like it, subscribe, comment, and thanks for watching.